earlier technologies that were tried and used for doing some of these automation, not as reliable and robust. And so that's why in the age of AI, computer vision, that opportunistic screening has its own and sort of a new discussion and dialogue. And this was evident throughout the exhibition, both in the scientific and educational program, but even in the exhibit hall. I think some of the newer and more interesting, frankly, AI vendors showing for the first time this year, many of them were focused, not even, if not solely, but had a large story around this opportunistic screening capabilities that their models, their algorithms are able to do. Now, however, like most things in medicine, it is a system problem, right? You can't just have an AI that looks at that CT study and flags a calcification or looks at maybe a fracture that was not highlighted in the report. You need to consider, well, how does that information flow? Who then deals with that information? One of the critiques of this type of a use case has been, well, the radiologist is not going to get extra reimbursement for this, and so them purchasing this tool or using it is not going to increase the revenue or the workflow benefits to the radiology practice. And whereas that may be true, the benefit in a fee-for-service world is that other service lines are seeing some additional patients. Now, you could argue that maybe they're going to get unnecessary tests, but nonetheless, you're getting those patients that otherwise would have been missed into the system. And so then in a fee-for-service world, that's good. In a fee-for-value world, you're getting patients that may have otherwise not have gotten that attention, earlier detection of disease or condition. Now, the more reliability, lots of practical issues. And for instance, John Garrett did a very nice talk mentioning that, well, the more you rely on automation techniques to do these opportunistic screens, you need to really pay a lot more attention now to the quality of your input data. How do you normalize your data in terms of protocoling at the scanner, in terms of the presentation states of the information that go into the models? How do you semantically interoperate these systems together? So it's not just purely about the computer vision model, but also to how do you put this into context? But a very interesting point that I had frankly never heard before that Arun Krishnaraj mentioned was that if we shift our mindset a bit from not just even opportunistic screening, but doing more of these intentional screenings using these biomarkers that the evidence is accruing that these different imaging biomarkers do correlate to different risk profiles, that perhaps as we get more evidence and secure in our belief in these things, that even the role of the radiologist could shift from being more of just a diagnostician reading, but in fact, providing these capabilities as a part of the primary care pathway, that instead of, or as an augment to your yearly annual, the radiologist is looking at and prescribing some different screening tests and exams, looking at those biomarkers, using AI to better correlate them, and then in fact giving some more evidence and quantification for that visit. So an interesting proposition, again, fraught with real world challenges and difficulties, but it is intriguing. And again, it speaks to, I think, some of the utility and where computer vision AI can be really used in the day-to-day, which I thought was very interesting, something I hadn't really seen mentioned before, and very aspirational, but nonetheless, it does speak to, I think, some of the interesting areas and where the technologies, especially in deep learning, rightly applied, can really have an impact. But like most of these things, we need to think about the entire system and how are the overall benefits going to outweigh the cons. So thanks for your attention.